I can just see Dr. Saumitra joined, but his audio is in mute and video is off.
Dr.
Dr. Saumitra.
Saumitra?
I think we
Dr.
can move.
Saumitra?
Hello.
Hi, Dr. Saumitra. So today we are at first going to present the patient story, followed by the session. So
Okay.
can you present the patient story first?
Yeah. Am I audible, sir?
Yes, yes, you are.
Hello. Yeah.
You are audible.
Thank you. Yeah. I'm Dr. Soumitra Gawas from CHC working for DHS Goa. I would like to present my case. My patient is a 56-year-old female diagnosed of ovarian cancer with mets to liver with subacute bowel obstruction. Next slide, please. Patient presented with chief complaints of abdominal pain for 6 to 5 days, constipation for 5 days, nausea and vomiting on and off, and weight loss. Next slide. History of illness. Patient was diagnosed with high-grade ovarian tumor in 2020 at the government hospital, for which the patient received neoadjuvant chemoradiation. The details of those radiation and the treatment which was received by the patient was not clear or not known. Now the patient presents with abdominal pain in the umbilical and the suprapubic region, gradually increasing from a dull aching in character to colicky pain over the last 3 to 5 days with associated nausea and vomiting. The pain was in character 7/10. There's decrease in oral intake by the patient over the last 3 to 5 days, along with giddiness. Next slide, please. Examination. The patient is conscious, oriented in time, place, and person, poorly dressed, emaciated, thinly built, temperature is afebrile, BP 88 beats per minute, pulse 88 beats per minute, BP 110/60, icterus is positive, pallor is positive. Per abdomen, the abdomen appears distended, guarding is positive, hard palatable swelling is felt in the suprapubic region. Next slide. The patient treatment and significant investigations. Routine investigation shows hemoglobin of 6.6 milligram per deciliter. Total counts are raised to 12,000. LFT serum bilirubin, total bilirubin is 3.6, direct is 2.1. SGOT is 1,540, SGPT is 1,460, RFT is blood urea is 67, serum create is 1.6. Ultrasound abdomen, liver shows mixed echogenicity with dilated bowel loops with minimal free fluid in the pouch of Morrison's, with right ovarian mass measuring 6 cm by 7.2 cm, with heterogeneous echogenicity, with retroperitoneal lymph node enlargement. Next slide. Psychosocial aspect. Patient is a 56-year-old widow living alone in her own home. Son has expired 5 years ago back of ALD. Source of income from the husband's pension and other government schemes. Some monetary and household support is provided by her nephew. She says she has no one left to live in the world and doesn't want to become a burden on her nephew who has his own children to look after. The nephew himself cannot afford for any more expenses nor divert his time for the patient as he has his own family and job to look after. Next, medications. The patient receives morphine 5 milligrams QID, syrup lactulose 15 ml TDS, tab pantoprazole 40 milligrams OD, tab antacid TDS, tab ursodeoxycholic acid 150 milligram TDS, tab vitamin B plex OD, and tab dicyclomine hydrochloride 20 milligram TDS. Next slide. Main concern for this patient is the abdominal pain and GI related issues, the nutrition of the patient, and the financial and the social support that the patient requires. Next slide. Summary. The patient is a 56-year-old female with ovarian tumor with mets to liver with subacute abdominal obstruction with moderate anemia, require nutrition and psychosocial community support. Next slide. Discussion points about this patient. What can be done to alleviate the abdominal pain of the patient? how to tackle the current GI-related complaints of the patient and what can be done to support the patient financially and psychosocially. Thank you, sir. Yeah. Hello. Hello. Yeah, so that's
I'm
my
not
case, sir.
Yeah, thank you. So we have a
Thank you, sir.
56-year-old woman who is diagnosed with the carcinoma of the ovary, underwent neoadjuvant chemo radiotherapy in 2020. And later she presented with abdominal pain, which is colic in nature, along with the constipation, nausea, and vomiting. So, what would you consider? What is the diagnosis? I would like to ask everybody, what would be your diagnosis if a patient with carcinoma of the ovary presenting with abdominal pain, nausea, vomiting, and constipation?
Hello. Yeah.
Uh,
So Dr. Soumitra, so it can be a mucinous tumor of the ovary with mats which can be extending to the peritoneum, causing obstruction, adhesions in the patients, causing subacute bowel obstruction.
Okay. I would like to ask anybody else what would be the diagnosis? Intestinal obstruction, Dr. Rundali says. Okay, obstruction, local spread, intestinal obstruction, ascites. Okay. So, why do we say that this patient has intestinal obstruction? Or what are the typical features of intestinal obstruction? Can anybody tell me? What are the classical clinical symptoms of intestinal obstruction?
Abdominal distension, abdominal pain, acute.
Okay, thank you, Raisa. Anybody else? Not passing motion, abdominal distension, vomiting, constipation. Yeah, the classical clinical picture of intestinal obstruction is one is abdominal pain. Usually it is colic in nature. Then constipation. Then nausea and vomiting. So these are the three features of intestinal obstruction. Patient may or may not have abdominal distension depending on the site of obstruction. So, is this a complete intestinal obstruction or a partial intestinal obstruction? Or how would you differentiate between partial intestinal obstruction and complete intestinal obstruction from the history?
Alternate constipation and diarrhea, it will suggest as a partial intestinal obstruction.
Okay. When would you say it is a complete intestinal obstruction?
If the patient is not passing any stool for more than 4 to 5 days and he's complaining of vomiting and pain in abdomen.
Okay, thank you, Dr. Aditi. I can see Dr. Dilip Pawar. Yeah.
If the patient says there is absolutely no gas also coming out,
Yeah.
then
So,
we can consider.
if there is no flatus, that means the patient has complete intestinal obstruction. So, if the patient is passing flatus, that is considered as incomplete obstruction. Okay. So, obstruction can be two types: complete or incomplete obstruction. So, here, Dr. Soumitra, what was this patient having? Is she passing flatus or is she not passing flatus?
Hello. So yeah, she was passing flatus.
Okay. So she is passing flatus. That means this patient has incomplete intestinal obstruction. So we have made a clinical diagnosis of intestinal obstruction. What was the frequency of vomiting, and how much was the volume? From this, we can get a rough idea of where is the obstruction. So, what was the time? How many times she was vomiting, or
So
what was the frequency? Yeah.
vomiting was 2 or 3 episodes, but the volume frequency was 2 to 3 episodes. Volume was not known, sir. She couldn't quantify how much the volume was, not the relative.
Okay.
She came to me in an emergency setting for abdominal pain mostly.
Hmm. Okay. Usually, low frequency, high volume vomiters is the feature of upper GI obstruction. Okay, suppose the patient has gastric outlet obstruction. The patient will vomit out lot of intestinal contents, but as she is vomiting all the contents, the frequency of vomiting will be less. But in case of if the obstruction is below, then the patient will have more of nausea and frequent vomiting, but it will be of less quantity. Okay, so this is the rough symptoms by which we can say, okay, is it lower GI obstruction or is it upper GI obstruction? Okay, once we diagnose, okay, this patient has incomplete intestinal obstruction, and probably I understand that. Dr. Swamitra, was an oncology opinion taken for this patient? Dr. Swamitra? Okay, anyway, Dr. Swamitra, if you are able to unmute, please unmute yourself.
Yes, sir. Hello, sir. Yeah.
Yeah. So I was asking whether an oncology opinion was taken for this patient when.
Yes, sir.
Yeah.
Yes, sir. The patient was referred for oncology.
Okay. So what was their opinion regarding? Are there anything that can be done from oncology?
No, sir. She was when I had referred her, she was not started on that morphine, but they started on her morphine, and syrup-lactulose was given for that constipation. Nothing else was done. I didn't find any other reports in the emergency department for this patient.
This patient, I'm not sure whether she probably she has an advanced malignancy,
Yes.
and her liver functions are totally deranged, and even
Yeah.
renal function is also deranged.
Also
Uh,
deranged.
yeah. Uh, so um, we can there are two types of management. One is conservative management and the other would be managed surgically, but if the patient has advanced malignancy, then probably that patient may not be fit for surgery. So we will not talk on that matter, but how do we manage patients with intestinal obstruction conservatively? What all should we do for these patients? Any idea? Okay, and before going to the management as such, what could be the causes of intestinal obstruction? Worms, yeah, rarely. Yeah, adhesions, metastasis. Yes. So, what is the most common cause of what is the most common malignancy which causes intestinal obstruction? Most common malignancy which causes intestinal obstruction. You can see CA colon. Dr. Dilip also says CA colon. Okay. But CA colon is the second most common cause of intestinal obstruction due to malignancy. And carcinoma of the ovary is the primary or most common cause of intestinal obstruction. Okay. So the intestinal obstruction can be of two types. One is mechanical obstruction, and the other one is functional obstruction. So in case of mechanical obstruction, what happens? There is a mass in the intestine which obstructs the fecal matter which comes down. So it can be due to obstipation, that means absolute constipation, or it can be a tumor mass inside the intestinal lumen, or it can be intramural, that means within the muscular layers of the intestine, or it can be compression from outside the intestine, like enlarged lymph nodes pressing on the intestine, which can cause obstruction. So these are the and even additions which can cause obstruction. So that are the mechanical cause. What is the functional obstruction? Functional obstruction, there is no mechanical obstruction, but still intestine is not functioning. That means there is no peristalsis. So this can occur in probably due to hypokalemia, or if there is malignant infiltration of nerve plexus to the intestine. Okay, so mechanical obstruction and functional obstruction. One of the important features of intestinal obstruction in malignancy is that usually obstruction is at multiple sites. That means it is not at a single site. Obstruction can occur at multiple sites. So even if you do surgery, that may not be having much advantage for the patient. And the etiology may also be there is a combination of mechanical as well as functional bowel obstruction. So these are the two things which we should be careful in treating intestinal obstruction in patients who has advanced malignancy. So we are talking about patients who has advanced malignancy. Okay. So once we diagnose intestinal obstruction, then we have to see whether this patient has abdominal pain or this patient does not have abdominal pain, because management usually includes steroids. So why do you use steroids in case of intestinal obstruction? Anybody? Why should we use steroids?
To reduce inflammation.
Yeah. So I told you that if there is a tumor, either inside the intestine lumen or intramural, or if there is a tumor pressing on the intestine, there would be peritumor edema. Okay. So if you give steroids, what happens is this peritumor edema will be decreased, so that the lumen of the intestine, there would be we can create some passage. Okay, So if you reduce the edema of a tumor mass which is pressing over the intestine, the compression of the intestine is reduced so that a passage is created. So that's the first thing which we usually use. And there is some evidence to say that steroids like dexamethasone in the range of 8 to 12 milligram is beneficial to treat intestinal obstruction. So that is the important thing. And what happens in intestinal obstruction, or how the symptoms which I explained, one is colicky pain, constipation, and nausea and vomiting. How does this occur? What is the pathophysiology happening? So when there is an obstruction in the intestine, what happens is the food contents and the secretions will get collected at the site of obstruction, and this will distend the intestine. This distension is a cause for more secretions. Okay, and there will be more secretions, which will again cause distension of the intestine. And so this distension secretion is a vicious cycle. So what happens? There is an obstruction here, and suppose it is in the second part of duodenum. There is an obstruction. The intestine is getting filled and it is getting distended. So what would be the symptoms?
Vomiting.
Yeah, because the food and the secretions are not passing down as usual. So that will come out, and or it can cause reverse peristalsis, and that causes nausea and vomiting. Okay, and as there is an obstruction, the food particles which is digested is not coming down. That will cause constipation. And when there is an obstruction, the intestine itself will try to remove the obstruction. How would intestine try to remove the obstruction? What is the mechanism?
Peristalsis.
Yeah. So the intestine will increase the peristalsis to remove the obstruction. So when there is increase in peristalsis, what would be the symptom?
Pain, colicky abdominal pain.
Yeah, colicky abdominal pain. So this is how all these symptoms occur. So that will cause constipation, nausea and vomiting, and colicky abdominal pain. So which are the classical clinical symptoms of intestinal obstruction? So we told that we would use injection dexamethasone in the range of 8 to 12 milligrams. Then what else need to be used to treat intestinal obstruction?
Laxatives to clear the bowels.
Yeah. What type of laxatives would you use?
Prokinetics can we use?
Prokinetics. Yeah, but what can happen if the patient has colicky abdominal pain?
It will improve the colicky abdominal pain. We will use prokinetics, I guess.
So metoclopramide, which is the prokinetic which is usually used, that also increases the peristalsis. So the patient already has increased peristalsis due to obstruction, and that is causing colicky pain. And then you add injection metoclopramide, which is again going to increase the peristalsis, which will cause more pain. Okay. So if there is pain, you should not use prokinetic.
So lactulose.
Lactulose. Okay. The preferred thing is you have to do a rectal examination and give high enema. So I'm not sure whether you know about what is hyperemia. So in hyperemia, what is done is, first of all, you do a rectal examination, and if the rectum is ballooned, or is it, or if it is roomy rectum, that means when you do PR, you feel a lot of space around it. That is called roomy rectum or balloony rectum, which is an indication that there is some obstruction in the upper intestine or somewhere else in the intestine. Okay. So in such cases, you pass a Foley's catheter or a suction tube into the rectum, and gently push it into the rectum till it goes, and then given enema. So what does that mean is, we are expecting that this Foley's catheter or the suction catheter will bypass the obstruction and will deposit enema above the level of obstruction, so that the fecal matter will get liquefied, and that will help the patient to pass motion. Okay, so this is known as hyperemia. So this is what usually done for patients with intestinal obstruction. So first thing is steroid. Second thing is the rectal examination. If there is loaded rectum, you have to digitally evacuate it, and then hyperemia. What is the next thing? The pathophysiology, the important pathophysiology in case of intestinal obstruction is, as I told you, more secretion, abdominal distension, secretion, abdominal distension. That's a vicious cycle. So you have to reduce the secretion. So what would you do to reduce the intestinal secretion? What are the medications that can help to reduce intestinal secretion?
Glycopyrrolate.
Yeah, glycopyrrolate. Yeah, that's right. Yeah, you can see that Dr. Vineetha says octreotide. Yes, that's also right. But what is the problem with glycopyrrolate? What are the other actions of glycopyrrolate? It will reduce the secretion. Yes, that's right. But what is the other action?
Causes dryness.
Yes. So reducing secretion, it's a part of dryness is also part of that.
Urinary retention.
Okay, so you are talking about anticholinergic side effects. But what else is the action in the intestine? Reduces the secretion, and it is an antispasmodic as well, isn't it? So it can reduce the spasm of the intestine. That means it will reduce the it will relax the smooth muscle of intestine, and that will help to reduce pain. Okay, so glycopyrrolate has two actions. One is it relaxes the intestinal smooth muscle, which will help to reduce the colicky pain, as well as it will reduce the secretion. But if you continue to give glycopyrrolate, the intestine will go into paralysis, isn't it? So that will add to more of functional obstruction. So we are, if you continue to give or continuous infusion of glycopyrrolate, that can lead to paralysis, or it will add to constipation. So glycopyrrolate and hyoscine butyl bromide, both these can be used, but the problem is that it will cause, it will add to the constipation because it relaxes the smooth muscles of the intestine. What are the other medications which can reduce the secretion without causing paralysis of the intestinal smooth muscles.
So anti-diarrheal drugs like loperamide and risperidone.
That also would reduce the intestinal movements, isn't it?
Rifaximin.
So what we can use is ranitidine. Okay. So ranitidine, that group of medications which can reduce the secretion, as well as PPAs, proton pump inhibitors. But usually preferred one is ranitidine. Okay. So give injection dexamethasone. So we are just discussing the patient story only. You will have a session on this. Good. Okay. So you have to give steroid. You can give. You have to do a rectal examination, digital rectal evacuation, and enema. Then to reduce the secretion, you can use ranitidine. Then if the patient has pain, you should not use bisacodyl or sodium bicosulfate, anything like that, because that will also induce peristalsis. So you can use liquid paraffin. So this is what you would use if the patient has pain. But if the patient has intestinal obstruction, partial intestinal obstruction, and if the patient has no pain, then you can actually give prokinetics as well as stimulant laxatives like bisacodyl. Okay. And in this patient, there is nobody for her to look after, only a nephew. And the patient thinks that she will be a burden for the nephew. So what we can do is maybe there would be some care homes or things like that, or you have to get the help of volunteers so that they can help her to live, so that they would be able to support her in the psychosocial aspects. So I think our faculty has joined, and Vineetha, are you there?
Yes, yes, I
Okay.
am here.
Yeah.
Sorry for
Today
the
we have discussed the so we were discussing the case history. So now we will move on to the session as such. So today we are going to cover two important subjects. One is constipation and the other one is intestinal obstruction. And Dr. Vineetha will be speaking to us regarding these two subjects. She's a MD in community medicine from Amrita Institute of Medical Sciences, but she has done her post-graduation in palliative care as well from Cardiff University, UK, as well as from Institute of Palliative Medicine, Calicut. She has worked with Aster, Calicut, and Kochi, and presently she is working at Lakeshore Hospital, Kochi, as a palliative care consultant. So she has been working with oncologists to integrate palliative care into oncology. So Vineetha, welcome, and it's over to you.
Thank you so much. And thank you so much for taking up the discussion, the case discussion also. And we could, in fact, give a more clear view about today's topic to our participants. Because sometimes when you start talking from the applied level, it makes more sense rather than when we start off from pure theoretical level. So having said that, a very good afternoon to all of you. And today I have been assigned to discuss with you on constipation and bowel obstruction. So let me just first share my slides. Yes, is my slides moving?
Yes, ma'am, it's moving.
Yeah, okay, thank you. Yes, so today we will be looking into constipation and bowel obstruction, and what I intend to is discuss the causes of constipation and malignant bowel obstruction, and also how you can identify these issues in your patients and how to come to a diagnosis, and also what to do further once you diagnose them. How can you manage these patients? So be it pharmacological or non-pharmacological, right? So as we start off, again, I would like to bring your attention to a case scenario over here. Okay, this is a case scenario that I would like each one of you to keep in your mind as we go through the class, because when you read this right now, I want you to have a kind of idea on what could be the reason and what are your answers to the questions at the end, and if there will be a change to those answers by the end of today's class. Okay, so here is a 54-year-old lady. Okay, she's a very old, frail lady with gastric carcinoma on chemotherapy and was admitted in the general ward for treatment of UTI. And she is admitted with complaints of vomiting, abdominal colic, and fever. And she is very tired and is admitted also for completion of her IV antibiotic. Now, she is also having small, frequent, incomplete bowel movements for 4 days and is being started on laxatives. She is accompanied by her younger daughter. So, as you can see, it's a CA stomach patient on chemo. Now she's in the ward. She has a UTI. She's having complaints of vomiting, abdominal colic pain, fever, and she's very tired. And she's put in there for IV antibiotic. And she's having small, frequent, incomplete bowel movements and is on laxatives. Has been started on laxatives, and she has a younger daughter with her. Okay, so now the question is, what are the issues over here that strikes to you? How would you investigate and how would you manage this patient? Okay, so just before we come to what could be the reasons, let's move on to today's topic, and we'll come back to this case scenario. Okay, so I would like to put the question forward. What do you mean by constipation? Yeah, we are going to be looking at constipation. We are also going to be looking at bowel obstruction. Now, what is constipation actually in simple terms? Okay, in just simple terms. When your patient comes to you and tells you, doctor, I am constipated, or tells you in the ward to the sister that, sister, I am constipated. What exactly is it that they mean and what you have to ask to know whether they are really constipated? Yes. Can we have the answers in the chat box, or whether you like to say it loud?
Difficult and
Yes.
irregular passing of stools at infrequent.
Yeah, so it could be anything. Like De Silva said, difficulty in passing stools, or Vincent said cannot defecate, or Pratibha says not passing motion for 2 to 3 days. Yeah, it can be any of these, right? Now, what would you like to ask them? This is probably what they mean. Absolutely. Urmila says, patients' regular bowel habits. Now, this is a very, very important question. Okay, because there are people who have There are people who have their normal bowel movements like once every other day. Okay, that's normal for them. But probably there are people who have normal bowel movements at least twice in a day, and that's normal for them. So your question to your patient should be, how different is it from your normal? And also there is another comment: hard stools are less than 3 proper bowel movements per week. Okay. And also De Silva says, are your stools hard, is another question that you could ask your patient. Absolutely. Thank you so much for those answers. So let's move on. So constipation, just like how you all were saying, it's difficult or painful defecation and is associated with infrequent bowel evacuations and hard feces. Okay. So it's always mostly a subjective feeling, and that is why you need to ask them, how is it different from your normal? Now, 45% of palliative care patients are constipated on admission. In my department, where I see mostly cancer patients, most of them, almost like say 90% of them, are having issues of constipation, unless and until you intervene with laxatives, because the cancer treatment per se does cause a lot of constipation. Most of the drugs can cause, not all, but most of the drugs can cause constipation. Right? So what are the symptoms that a patient can present to you with constipation? So probably your patient is not going to tell you upfront, doctor, I have constipation, or sister, I have difficulty in passing stools. So what are the other things that when you hear, you should ask the leading question about questioning how his bowel movements are? So what are the symptoms? Yes. What are the symptoms of constipation? Incomplete sense of evacuation, hard painful defecation. Yes. Deshain Ukyab says that. Yes. What else? What else could your patient be having a symptom? Straining. Dr. Kurtz says straining.
Urinary problems also it can cause.
Yes, it's well seen in especially elderly bedridden patients. Most of the time, most of the time this has happened to me when I go for home care, and at home the patient we get the call saying that the patient is not passing urine, or sometimes we get a call saying that the catheter is blocked, urine is not passing through the catheter. And sometimes what happens is that they just ask for, we want to change the Foley's, could you please come, because there seems to be a block in the Foley's. But when you push, there is, when you flush the catheter, there's absolutely, some issue over there, but we try changing the catheter. But what is most important is also when it comes to bedridden patients is asking about the last stool fast. Okay, so like you said, it can cause, definitely it can cause urinary retention. So yes, we also have other answers over here by Kalyani. Abdominal distension, decreased appetite, insomnia due to abdominal discomfort. It's lovely. And also De Salva says many patients complain about perennial bleeding due to hard stools. Very common. So what happens is that they try to strain while passing hard stools. Sometimes they also use their fingers to digitally evacuate the hard stools which are kind of stuck. So that can cause also injury and bleeding. And it's a vicious cycle, right? Once there is an anal injury, what happens is that the patient is not able to pass stools because there is pain in the anal area, and when they try to strain, there is again increase in the pain, which will in turn lead to constipation, right? So again, we also have, yes, Raiza was talking about urinary leakage through follies. Absolutely. That is also something that we see. There may be bladder spasms that occur. It can be, when you have your patients at home care, one thing that we have seen sometimes they say there is a leak, and most of the times, like you rightly said, it could be because there is a loaded colon, the loaded rectum. Sorry, there's a loaded rectum. And sometimes we also see because there is a overinflated bulb or something of the follies. Okay, so these are all different symptoms that you can see among your patients, right? Feeling of incomplete evacuation, bloated feeling, nausea and vomiting. Yeah, sometimes patients present to you with abdominal distension, nausea, vomiting, right? Also colicky abdominal pain, bowel obstruction, overflow diarrhea. So that is one thing also that we come across. It's not uncommon. I'm sure most of you have seen this. But what happens is that the patient comes to you and tells you that he's having loose stools, and before you, if you do not ask them the very, very, very vital question, when is the last time you had a normal stool, you will miss the overflow diarrhea. So coming to that, what is overflow diarrhea? Could you tell me what is overflow diarrhea?
Yeah, the patient is constipated, but they will pass loose
Yes.
small amounts.
Yes.
Frequently passing loose stools. Passing of loose stools frequently.
Yes. Due to prolonged constipation, right? So what happens is that when there is a prolonged constipation, the upper part of the collected stools tend to kind of liquefy, and that tends to kind of leak through out. So patients interpret it as loose stools, but actually there are two things which will tell you that you are looking at overflow diarrhea. One is by asking them the history. When is the last time you had passed your stools? And second, you do a digital examination for rectal examination, and if you see that the rectum is loaded, you are looking at overflow diarrhea. Okay, so actually the management is completely opposite, right? If when your patient comes and tells you that I'm having loose stools and it is actually a overflow diarrhea, what if you do not ask them more, and you tend to treat it like a diarrhea? It is going to worsen the constipation. Whereas overflow diarrhea has to be treated like constipation. You have to do a digital evacuation if required, give an enema, or give laxatives, whichever is appropriate for that time, right? And that is how you would manage. So like you see, the management itself is in two different columns, right? So it is very important to understand whether you are looking at plain diarrhea or a overflow diarrhea. Okay, and yes, we also have long answers like Ranjit has said about long-term constipation and escaping fluid through, okay, and mucosal irritation from hard stools. Okay, and like we were discussing, like you all were saying, urinary retention is also again another symptom. So now that we know, okay, these are the symptoms that your patient could come to you with, what are the causes? What are the causes for constipation? Yes. What are the causes for constipation? Yes, Gaurav says mechanical, Jason says opioids, Raisa says bedridden, lack of activity, Gaurav says functional also, yes, Saumitra says dehydration, yes. Along with the opioids, would you like to add something more? Yes, well, we are also talking about, yes, Dr. Dilip was saying complications. Complications of various, probably he was referring to complications of surgeries or RT radiation, I guess, right? And okay, hypokalemia, yes. Soumitra was talking about hypokalemia, where the peristalsis itself is reduced. Yes, Dr. Dilip was saying, okay, you were meaning about the fibrosis. Yes. Okay. And yeah, Shilpa was talking about the diet. The diet, something so simple. Okay, so a diet could also be a reason for constipation. Yes, Aditi says malignancy. And Darshana also says about metastasis. Urmila says gastritis. Okay. Kalyani says about decreased intake. Yeah. And Nazima says about dehydration, less fiber diet. Yes. Dr. Dilip was saying, clarifying more on that. It is about the complications of radiation that he meant, about the fibrosis. Yes, and again, we have answers like from Raisa and Upakal saying metastasis or can be cancer. And Angela says about the side effect of drugs. Yes, there is not just the opioids that are the culprits, but there are so many other drugs that can cause constipation. Inadequate fiber in the diet, again, opioids. Ravindra says neuropathy. Yes. Nazima says morphine. Yes. So we have so many different reasons that can lead to constipation. So exactly why constipation is becoming one of the most common symptoms that your patient is suffering from, right? So let's have a look. Pharmacological, you have the opioids, the antidepressants, anticholinergics, anti-epileptics, anti-emetics, like ondansetron, right? Then antacids, somatostatin analogs, like just how the discussion was going on with Dr. Sunil when he was discussing about the side effects of using anti-secretory drugs. Sometimes it can cause dryness, and that sometimes that itself can worsen the constipation. So it's like a double-edged sword, right? So you just have to be careful enough to balance it. Now, metabolic, there is, like you rightly said, hypokalemia, also hypercalcemia and uremia, apart from dehydration. Now, diet, yes, poor appetite, low fluid and low fiber intake. Yeah. Environment. Now, this is something that we hardly give much importance to. Where is the patient's privacy given importance to? Now, if the patient is being looked after by a male attendant, the patient is probably a female patient. There are chances that the patient is going to be constipated. Or probably there is a very elderly spouse who is looking into the elderly gentleman who is suffering from a cancer and bedridden. So most often the elderly wife is unable to support the husband by making the husband sit up on the bed and take the patient to the commode. So all this can be reasons also why the patient is constipated. Like when I used to go for home care, and I used to ask about bowel history, and they used to say yes, constipation is there. And I asked them, so when was it that you had a normal stool last? And an example, what I'm saying is that he would tell me like 2 days back. And I would when I would ask to such patients, so why is it that you have not been able to? Is it that you had been drinking water less, or you ask them few leading questions? So then you understand that actually it is a practice that is being followed. That is because the caretakers, who are the family members, they are probably working. and they do not have time to actually put a suppository, so that once after all the soiling and all that, cleaning up the sheets, cleaning up the bed, bathing the patient right after it, so they don't have time for it. So what they do is that they keep a timetable themselves. Okay, we shall put suppository for him every 3 days, that way. But what is in turn happening is that the patient is getting constipated, abdominal distension, and by the second day evening, he is unable to take his food properly. So he is developing nausea, he is developing gaseous distension, all this happens. But they just do not understand, probably it could be because of this. So like I was saying, environment is also a very neglected cause for constipation. Then, of course, neurological reasons like malignant spinal cord compression, spinal nerve infiltrations, like the sacral nerves getting infiltrated. Now, structural, it can be probably as obstruction there, like the pelvic tumors, RT-induced fibrosis, like Dr. Dilip was saying, and painful anorectal conditions, like how I was earlier talking about, sometimes there is an injury in the anal canal, and then every time they try to strain and the anal canal expands, there is a pain again that comes, that they are unable to strain further for a bowel evacuation, right? So RT-induced fibrosis, painful anorectal condition, intraluminal obstruction. There could be some mass actually sitting there and causing the obstruction. Now others, like I think it was Gaurav who was saying about how it could be also functional, right? So it could be depression, it could be also weakness, immobility, inactivity, sedation, old age. All these things are different reasons why it can cause constipation. Okay. Yes, Abish also talks about diabetes, which could probably lead on to neuropathy and things like that, leading to constipation. Intake of meat and less water intake. Be it any high fiber diet and there is no enough water, that itself also can probably lead to one of the reasons for constipation. Okay. So assessment is first and foremost question, what is normal for the patient? Then ask, what is the frequency, how much amount, the consistency, is it blood stained or not? When was the last bowel movement? Is the patient experiencing any discomfort because of that? Like pain, colic, nausea, vomiting, gassy feeling, or rectal fullness. So, does the patient regularly use laxatives? This is like $1 million question. Okay, are you using the laxative? I have often had to counsel patients on the use of laxatives because they are very upset if their bowel movements are not right, but at the same time they are very scared to take laxatives. Why they are so scared is because the last time they took, if you ask them, they will correctly tell you, last time I took laxatives, it was just there was just loose stools for 2-3 days, so I'm very scared. So this is what they tell you. So what you have to educate them is that if there is a cause for recurrent constipation in them, they should make it a practice to take laxatives maybe daily or like in an alternate fashion, especially if there are drugs that they are on which could be causing constipation. They better have it daily, regularly. Okay. Otherwise, what happens is that they tend to have chronic constipation, and when there is accumulated fecal mass and then the patient takes laxatives, obviously there is going to be a purge, and this could probably result in some diarrhea or incontinence. Okay, so this has to be explained to them, and that is the only way how they can prevent constipation and be confident enough to use laxatives. Okay, so what medications are the patient on? You need to rule out if there is any culprit among the medications that the patient is taking, right? And if the constipation is severe, maybe even rotating those medications or choosing other alternatives. Now, is the constipation a recent change? Now, when you are dealing with patients, especially like in oncology patients and cancer patients, when the patient tells you that there is a change in the bowel habits and things like that, is it a recent change? You could be looking into something new over there, okay, which may warrant further investigation. It could be some colonic deposits or some pelvic tumors, which is in turn leading to constipation. So be careful not to miss that. What type of diet is the patient on? So is the patient deficient? I mean, is the diet deficient on fluids and fiber is also important enough. Okay. Now, common issues. What happens is that when you go and you try to ask the patient about constipation, immediately the family member may tell, but how will he pass stools? He's not eating at all, or she's not eating at all. So this is such a common question. All of you must have had to face this question. Now, what you need to make them understand is that even if the patient has not had enough food, there are intestinal secretions which could further lead to stool formation. Okay, so that has to be made to understand. And again, I have diarrhea, so that is again another common issue where you have to rule out overflow diarrhea. Okay. Now, large bowel transit takes about 3 to 4 days, even in normal people. So, stool contains shedding of the epithelium, and a major bulk is a byproduct of bacterial action. So, even if patient has not taken any food for a few days, he needs to evacuate his bowels. So now coming to management, correctable. So you have a list of a lot of causes, right? We have seen the different causes. So any of these causes, if it is reversible, go correct it. Go correct that first. Correct the correctable. Judicious use of laxatives, okay? Improve the general condition of the patient. And symptom control if it is associated with nausea, vomiting, pain. So control the symptoms of the patient. Encourage activity in the patient as much as possible. And diet, counsel on the diet of the patient. Now, there are some non-pharmacological management ways like accessibility to the toilet, timing and privacy, squatting position. If the patient is able to squat, that is the best position to avoid constipation and to beat constipation. So, also encourage normal, balanced diet and plenty of water. So, when you have your patient coming to you, always do a rectal examination, because there is no point giving laxatives up and right if the patient is having a loaded colon, dry fecal matter, which even if you put sometimes even if you give an enema, it's only the enema fluid which runs out and not the stools. So always do a rectal examination and digital evacuation if required, even to place a suppository for the patient. The family has to be counseled that when the patient places the suppository, of they are placing the suppository, or you can tell the patient if he himself is placing it or she herself is placing, or you can tell the family if the family is placing it for the patient, how it has to be in touch with the mucosal membrane of the rectum. Okay, and it is not just that they just insert it, and for all you know, it will be just inserted right into the fecal mass, which it is not going to cause any effect. Okay, so the proper use of the right laxatives, suppositories, enema, Proctolysis, glycerin enemas can be given. Warm saline enemas, plain water. Do not give soap and water enemas if possible. Digital evacuation for fecal impaction. Right now, again, coming to laxatives, there are different type of laxatives, right? And which are safe and good suppository is what Dr. Dilip was saying. Most often what we use is bisacodyl suppositories, and bisacodyl suppositories are pretty safe, and they also have a very good action. Only thing is that how it has to be placed, um, uh, such that it is touching the mucosal wall, and preferably it can be done after digital evacuation if there is fecal mass. And some people, okay, now this is one thing that you can also ask your patients, that have you used suppositories before? How was it? Was it helpful? Because sometimes bisacodyl suppositories, like it is a stimulant laxative, okay? Like you can see in the table over here, stimulant. Among the stimulant type of laxatives comes bisacodyl, that is Dulcolax. So what it does is that it causes, at the site, it causes contractions, okay? So it causes increased peristalsis and contractions, which helps to forward propel the fecal mass. So this can cause sometimes colicky pain for some patients, which is causes a lot of discomfort for them. So you can give them the choice, ask them if they have used suppositories before, but otherwise, by and large, it is always good and safe. Okay. And bulk forming laxatives and lubricating laxatives like mineral oils. So now castor oil and all that used to be used before, but sometimes aspirating, there is a chance. So you do not, as much as it is cheap and readily available, we do not often use castor oil nowadays, because there is a risk for aspiration. Okay, bulk forming laxatives are also good, but one thing you need to know, okay, if it is just a plain laxative, it is okay. It helps to increase the bulk of the stool, and that itself will help to induce contractions in the intestinal wall, which will help in the further propulsion of the fecal mass. Now, osmotic would be drawing in of water from the intestinal walls, helping to liquefy the stools, like lactulose. Now, one good thing about lactulose is also that I often tell my patients, because some of them are just so reluctant to have medicines for that is laxatives for constipation. They just say that no, I'll have fruits, I'll have this, I'll have that, but I don't want to take medication. So what sometimes I tell them, no, but this lactulose, it is actually good for your liver also. So that's how I get them to have some confidence in having lactulose. Now also milk of magnesia, peg laxatives, these are all good osmotic laxatives. Okay, then stool softness, docusate sodium is also very good, but somehow it is not easily available, right? Yeah. Now Dr. Kurt was talking about edible coconut oil. Yes, that is also there. And sometimes, like how we say to pour a teaspoon of oil or ghee into hot tea and have. So all these are different home remedies also that we tell our patient. Yes. So also, paraplegic patients need regular stimulants and stool softness. They also may need initial manual evacuation. Patients with colostomies are treated in the same manner. Okay. Patients with colostomies can also have constipation. They also may need digital evacuation. And also, suppositories can be given to such patients. So if it is soft stools, you can go for bisacodyl. If it's hard stools, you can go for glycerin suppository. Empty rectum, which Dr. Sunil So was talking about there is a ballooning of the rectum, which means that the fecal matter is high above. So for that, you will have to give oral stimulants, you will have to give high-end enema. Okay, so these are all what have to be done. And always remember, manual evacuation causes discomfort for the patient. It interrupts his privacy. So always explain properly, make sure that the environment has a lot of privacy, sufficient lubrication, and allowing for some time for the local anesthetics to act, and gently do the procedure, and you have to wait for the patient's reaction also, because if it is painful, you have to go really slowly, okay, and explain what you are doing. Okay, now moving on further, we have bowel obstruction. Okay, it is a little similar to constipation when it comes to the symptoms, but the causes are very different. You have, like how you were saying before, it could be functional, it could be mechanical, and that's exactly what it is. Now there are situations like non-mechanical obstruction. It could be just a functional obstruction. It could be adynamic bowel where there is no normal peristalsis, but it can also be mechanical, where it can be either acute or chronic. It can be in the small bowel, large bowel. It can be maybe just a simple one, or it is a closed loop obstruction, or it can be strangulated. Yeah, the blood supply itself is cut off. It can be intrinsic, extrinsic, intraluminal, where you will have the obstruction. It may be a mass which is infiltrating. So that can be intraluminal. There could be a mass which is sitting inside the lumen and causing the obstruction. It can be one which is outside the lumen of the intestine and causing a mass effect and thereby producing obstruction, or it can be intrinsic where it is invading through the muscle wall. Okay, so there can be again, the reasons can be many. It could be foreign bodies, it could be gallstones, it could be strictures, it could be malignancies, again adhesions, hernia, volvulus. And we were talking earlier about RT-induced fibrosis and things like that, right? So if your patient has undergone radiation, if your patient has gone surgeries, there is high possibility for causes such as strictures and adhesions, right? And this could also be the reason for the bowel obstruction in your patient. So also adynamic causes like paralytic, ileus, and mesenteric vascular occlusion. So now what causes the symptom? When there is a partial or complete bowel obstruction, there is a decreased movement of the intestinal contents, which itself will cause bowel distension. Okay. Now this also we need to understand that when there is partial or complete obstruction, there is also some amount of colicky pain. That was also same again discussed by Dr. Sunil, right? About the colicky pain, why it happens. So now you could be having the colicky pain because of this. Also, you could be having a bowel distension which is happening because there is decreased movement of the intestinal contents. Now, what happens when there is a bowel distension? Increased bowel contents are there, increased gut epithelial surface area, increased bowel secretions of water, sodium, all that, and this in turn is what triggers the nausea and vomiting. Leads to the nausea and vomiting. Now also there is a bowel inflammatory response that happens, which in turn leads to the vicious cycle of the pain that occurs. So the level of obstruction determines the pattern of symptoms. So generally, what happens is that you want to know where is the obstruction that has happened for this patient. You are going and visiting the patient at home, and the patient says that, oh, I'm just vomiting so much that I'm not even having so much of liquid. I don't know from where so much of fluid is coming. Just vomiting so much and so much. So when there is a high volume vomitus happens in small bowel obstructions. Okay. So that is a catch. You can know you are looking at a patient who is having a small bowel obstruction. Now, in large bowel obstructions, is rather progressive. They may give you a history of constipation and abdominal distension more rather than the nausea and vomiting. Nausea is there, but the vomiting is more profound in small bowel obstructions. Now, when there is complete obstruction, there is no flatus that is passed or no fecal mass. Okay, so there is no flatus, no motion that is passed when there is complete obstruction. And even when you examine the patient, there is no bowel sounds. There may not be spurious diarrhea. Again, there may be some leakage that is happening. So what do you do? How do you diagnose? First and foremost, you could take an X-ray, an erect abdominal X-ray, but often this does not happen for a patient who you are seeing at home care, right? You cannot ask the patient, okay, now please go and to the nearest imaging center, take an X-ray and come back. May be difficult. So managing a patient at home and managing a patient at home who is in a terminal phase and managing a patient at who is more in a definitive treatment and is up and about with a better performance status rather is a bit different. So you could order a erect abdominal X-ray for a patient with a better performance status, or probably someone who is not towards the terminal phase, right? Terminal days rather. So erect abdominal X-ray taken over here shows you multiple fluid levels, right? So multiple fluid levels. Let me see. Pointer option. Yes. So this is the multiple fluid levels, the straight line and the gas shadow on top of it. The straight line and the gas shadow on top of it. All the straight lines here and the gas shadow on top of this. And over here, actually, you can see, sorry. Yeah. So actually, you can see that the intestine itself is very dilated. The large bowels are distended over here. So poor surgical prognosis. Yes. So now what do you do? Do you manage this patient? You understood that the patient has bowel obstruction. Now what do? Do you push the patient for surgery, or do you manage them with medications? So yes. So what is it? Poor surgical prognosis is that for patients with advanced age who are cachexic, widespread tumor, deranged metabolic parameters, and those with ascites, low serum albumin, severe nutritional deficiency, or those with a huge palpable mass, or those who have undergone previously radiotherapy or a radiotherapy to the abdomen and pelvis. So this could be because there would be a lot of fibrosis, like earlier we were saying adhesions and fibrosis and things like that. History of combination therapy. Here what I meant is that multiple lines of chemo was being given or treatment was taken, which shows that it is a tough disease. It's more towards a poor prognostic disease. Okay, and multiple sites of obstruction. If there is one point of obstruction and the patient is having complete obstruction, probably with a good PS, you could ask your patient to go in for surgery with a colostomy. But what if there is multiple sites of obstruction? Right? Now, poor peristalsis due to diffuse carcinoma peritoni and generally poor performance status of the patient, all these tell you that it is better to manage this patient conservatively. Okay, so how do you manage a patient with bowel obstruction conservatively? Yes, what medications would help him with someone with a bowel obstruction, say a malignant bowel obstruction? Yes, chat box, or you can just say it. Someone with a malignant bowel obstruction and you want to manage with medications, what medications would you suggest? No answers. Yes, Soumitra says steroids. Absolutely. Steroid is the most important medication here. Yes, Dr. Dilip also agrees to it. It is what we generally use is dexamethasone. Okay, so dexamethasone can be given to about 12 to 16 milligram. It can be given. Yes, we have lots of answers coming here. I think it was just my net was slow. Now I see all these answers. Upakul, Dr. Kurt, Dr. Urusa, Angela. Angela was also talking about, yes, give laxatives, open up his bowels, yes. And Shilpa was also talking about deflating by means of Ryle's tube, antiemetics and steroids, absolutely. And Raisa also talks about enema. Okay, so all these are right, and we're just going to have a look at it. Drugs used, dexamethasone, this is what your prescription could look like. Dexamethasone 60 milligram, it can be given IV or subcutaneous, whichever is accessible. You can give a 3-day trial, check for flatus, passing of flatus, or decrease or passage of stools, and also bowel sounds can also be checked for. Metoclopramide 30 to 120 milligram over 24 hours. You can give it even as an infusion, or you can give regular boluses 8 hourly, or maybe frequently like 6 hourly. Hyoscine butyl bromide, we were talking about using anti-secretory agents for those who have severe vomiting, 40 to 100 milligram over 24 hours. Subcutaneous continuous infusion can be given in case of severe retractable symptoms and refractory symptoms. And haloperidol is also a very good antiemetic which can be used because most often what happens is that metoclopramide we are not able to use because the patient has severe abdominal colic. So metoclopramide, like you heard earlier, it can worsen the abdominal colic. So that is why haloperidol is another wonderful choice that we have. Okay. So any prokinetic, for that matter of fact, you have to ask the question to the patient: is the patient having abdominal? I mean, are you having pain, abdominal pain? If it is colicky in nature, most probably your prokinetic is going to make him more uncomfortable. If it is a partial obstruction, most of the times your prokinetic is going to help him a lot. Nazima also talks about Dulcolac suppository, and yes, you can use suppositories and enema because evacuating the bowels is also very important. Now, before we wind up, I just wanted to also highlight the fact that those patients with bowel obstructions who undergo colostomy, they have to be counseled about irrigation, bowel irrigation, because it is so important that they know how to irrigate their bowels and get their bowel evacuations through the colostomy happening in a timely fashion, rather than always there is like incontinence that is happening, and there is always a fear of soiling, there is a fear of odor, things like that. So they have to be counseled regarding that. I even know personally a orthopedic doctor who had a colostomy refused to go back to work because even after his treatment and after he had attained complete remission of the disease, because he was having the colostomy and he would not be able to stand for hours in the OT. So we taught him about irrigation, bowel irrigation, and it was so gratifying to see the next visit he came, he was talking about how he's joined that work. So because what happens is that, like you can see, this is the irrigation tube that is, you can see a nozzle in the end of it. inside the irrigation bag there is lukewarm water which is filled, okay, clear water, and through the nozzle which is fit into the ostomy tube, the water is made to run through. Now this has to be practiced every day in the morning at a same time, continuously for about 21 days. Okay, and after the water is let to run through, then take it out and you attach the sleeve and put the open end of the sleeve to the commode. So what happens is that the entire bowel is washed. Now this has to be practiced every day regularly, same time, say example 7:30 in the morning for 21 days, and then this becomes a habit for them, and they there is the stoma lets out the stools only at that particular time. Okay, so that is the good thing about teaching the patients bowel irrigation. So now coming on to the case, 54-year-old frail lady with CS stomach on chemotherapy admitted with UTI. She was admitted with vomiting, abdominal colic and fever, and she is tired and admitted for antibiotic. Small frequent incomplete bowel movements for 4 days, started on laxatives accompanied by daughter. So now let's focus on vomiting, abdominal colic and fever. What could be the reasons here for her abdominal colic? Vomiting, abdominal colic and fever. Her vomiting, abdominal colic and fever. What are the reasons? Yes? It could be because of the constipation per se. Yes. It could be because of the infection. Yes. So it could be anything, right? You have had a class on nausea and vomiting, and there are so many things which could be a reason, but pertaining to this case, we know it could be UTI per se, which causes the vomiting. It can also be that the patient is being constipated, that is causing the vomiting. Okay, like you all rightly said, and the abdominal colic also could have been part of it. Now you have here the other symptoms: small, frequent, incomplete bowel movements. And she's just been started on laxatives and she's accompanied by her younger doctor. Now, is there something that you see here? Another cause for the constipation. What I wanted to highlight over here is that which I was saying, that what we all take for granted. Absolutely, environment. Yes. And it is also, okay, it is also that there is an incomplete evacuation, probably because of that. And yes, like complaints to the laxatives, how much is she taking, we do not know, because she does not want to go to the toilet, or she doesn't want to use a washroom, which is in the ward. She's in the general ward. Her younger daughter has to support her, take her to the washroom. So maybe she is not comfortable enough with the environment, which is why she is having a prolonged constipation, right? Maybe because of the several drugs that she's put on. Okay, for her abdominal colic, what if she was put on hyoscine butyl bromide? So we do not know what could be. It could be also the anti-secretories, which is called the anticholinergic effects, which is causing constipation and things like that. So what are the issues here? I have highlighted them in red and blue. And how would you investigate? Okay, so well, you can do a digital rectal examination to actually see if there is impacted fecal mass. And also you can also check for well, here there is incomplete. Small frequent bowel movements are there. We are not probably looking at a absolute metabolic issue like hypokalemia or anything, but the patient was also having severe vomiting, which could have also led to some electrolyte imbalance, so that also we need to keep in mind. Okay, so this is what I wanted to highlight here. This is just an X-ray showing the impacted fecal mass. You can see that the colon is dilated. The intestines are so dilated. You can see like the fecal masses over there, right? That's what. So to summarize, evaluate, manage, monitor, and reassure your patient after you have checked on them, okay, and made the modifications required, and management, correct the correctable, non-pharmacological management, pharmacological management, and intervention if required. Also, it is not just the physical symptom, but also the psychological, spiritual, and the functional concerns of the patient that has to be managed on the whole, because in palliative care, we treat the patient as a whole. Okay, so these are my references for today, and thank you. Right?
Thank you, ma'am, for the wonderful session. Anybody have any doubts? So,
Yes, ma'am.
actually, madam, you had discussed about colostomy irrigation, or we have received on chat question when we can initiate the procedure.
The procedure can be initiated, I think, in at least 2 months' time. Thereafter the healing, after the surgery is being done, because the patient is performing it from home. So we can teach the patient one time, and then we are asking the patient to repeat it every day from home.
Okay, ma'am, one more doubt. When we are giving laxatives in a regularly basis, how much we should give? Like we used to give soft stool softeners and all, lactose. So how much and how frequently we can give?
Well, I usually recommend 2 suppositories, Dulcolax if it is bisacodyl suppositories 2 for adults, and if it is lactulose, I generally recommend 30 ml night dose, and if they have not passed, bowels have not opened by morning, I ask them to repeat it in the morning as well.
Okay, one more doubt. Actually, it is very costly, right? So, is there any recommendation for poor patients and all when they are taking regularly? It will be very costly. So they will not take it regularly.
That is one of the reasons why we had, in fact, always preferred for bisacodyl. That way, it is easily available also, and it is affordable also for the patients. And maybe lactulose, Clomafene, I think, is not as expensive as lactulose.
One more question, ma'am. Or prescribing antibiotics causing constipation? Is she had a multiple previous UTIs?
Yes. What if the patient was on previous antibiotics? Is that a reason? Or definitely. But also, one thing we have missed in that case scenario is that this patient is on chemotherapy, right? So even the chemo drugs, patient was probably on having constipation related to that also could be there, or the patient was probably put on antiemetics after chemotherapy, so probably something like ondansetron, that also could be there. So there are multiple reasons probably for that.
One more question, ma'am. Diabetes and aged patient regularly complaining of constipation. Which drug is good for that?
I usually prefer for such patients with lubricant like Clomafene Plus. Any of those commercial preparations which have lubricant, also liquid paraffin also along with it.
Thank you, ma'am. Any other questions?
And aged patients, they say osmotic laxatives is not, it's better to be kept as a second choice because it can lead to electrolyte disturbances. Yes, do we have any more questions?
No, ma'am. If they don't have any questions, we can wind up the session, ma'am. Can we?
Yeah, I guess we can.
Okay.
Ma'am, Ma'am,
Yes.
what about the diet? Like, can we counsel them for diet, like rich in fibers and fruits?
Yeah.
And like,
See, talking about the fibers, it's a very important question actually that you asked, because those patients who, say, suppose someone with, okay, I'm just going to give you a certain example. Say, someone who is having a CVA and is having constipation. Okay, I may also ask the patient, okay, add a little of fiber in your diet. But say, suppose someone who is having CA colon and is having constipation, that would not be something that I would be suggesting in order to avoid constipation, because there is more chances for obstruction by increasing the fiber in the diet rather than preventing constipation. So I guess it depends on the scenario, like what disease you are looking at.
and every patient is different, I guess. So we have to.
Yes. Yes.
Thank you.
Okay, thank you, ma'am. Thank you for the wonderful presentation. Thank you, the case person, for presenting a wonderful patient story. Thank you all. Thank you for joining the sessions. Thank you. Let's see in the next. Bye, ma'am. Bye, all. Bye.
Thank you, everybody. It was a wonderful session and a lot of interaction. Thank you so much.
Bye.
Bye. Thank you, Pavilion.
Bye.